Thanks very much for coming to this session on assisted dying and whether the time has come to legalise it. Hopefully most of you know me, but my name's Paul Weatherly, so I'm going to just chair this session. I'm really delighted that we're able to put this session on as part of the festival, because assisted dying is something, and the question of whether it should be legalised has become a much debated political and social issue. It's not something that's going to determine the outcome of the next general election, I don't think, but clearly it's something that's moved up the political agenda. It's an absolutely critical issue for the people who are affected by those issues, obviously. It also raises quite fundamental questions to do with the kind of values of our society, questions about ethics and rights. And it also, of course, raises issues about our political process and how our politics deals with these kinds of questions. So I'm really delighted to have three excellent speakers to come and talk about this with us. Just before I introduce them, I just want to, a couple of housekeeping things. One is to just ask that you all switch off your mobile phones. If you could do that, that'd be great. And the other one is to point out that we do have a film crew in the room. So all the speakers have said that they're okay with that, which is very kind of them. And so I'll just let you know that, really. If you're not happy with that, there's not much I can do. So hopefully you will be happy with that. So we've got three excellent speakers. Each one is going to talk for 15 to 20 minutes. So we should have time at the end for questions and discussion. First of all, we've got Sharon Young from Kingston University, who is researching issues around assisted dying, and we'll talk about her research, in particular in reference to kind of the discourse of rights around it. Then we're very glad to welcome Greg Judge from, I must make sure I get this right, from Disabled Activists for Dignity in Dying, who's going to talk about the issue from the particular perspective of that group and its position on the issue. And then I'm also very pleased to welcome our own Professor Michelle Briggs, who is the Professor of Nursing and co-director of the university's pain research team, who's going to look at this issue really more from a medical practitioner's point of view. Okay, so we're going to take those three talks consecutively and then open it up to questions and discussion at the end. So I hope you're all going to have a really enjoyable and interesting session, and I hope you'll join me in welcoming our three speakers.
Hello everybody, my name is Sharon Young. I'm a final year PhD student at Kingston in the Department of Politics and Human Rights. My thesis is looking at assisted dying from a human rights perspective. But I haven't always been an academic. In fact, I don't really consider myself an academic. I qualified in 1992 as a physiotherapist. And my first job was working with young men who were dying of AIDS at a busy London hospital. And I think that was a real shock for me, because in the early 1990s, the way men dying of AIDS, it was horrific. They were emaciated, they had persistent chest infections, and many of them had open sores covering their bodies. It was a really horrific way to die. And then throughout my career, I was often struck how, often two patients with a very similar diagnosis and very similar symptoms perceived and reacted very differently to their illness and dying. So really my thesis is a bit of a combination of my practitioner experience and an academic approach. So when we look at this question, is it time to legalise assisted dying, there are a series of sub-questions when I look at it from a rights perspective. Okay, so I want to know, why do we talk about a right to die? Is there a right to die? And part of my literature review has been looking at modern attitudes towards death from a historical, social, political context. And then you need to look further at what are the conceptual elements of a right to die, and whether a normative framework of human rights supports this. What does it mean to have a right to something? And of course, when you look at that, you need to examine whether the current legal position, what is that in the UK? Is there any need for change? And then I'm particularly interested in words. I want to know why we talk about a right to something. So when we talk about a right to die, who is it that's promoting this discourse? How is it being used? And does it really articulate what's important to people at the end of their lives? So who's promoting the idea of a right to die? Well, the media are. Don't know, on the television there'll have been a lot of coverage of particular individual cases, and national newspapers also cover cases. You might have heard of Tony Nicklinson, Paul Lamb, Debbie Purdy as well a few years ago. And then there are campaigning organisations such as the one Greg's going to talk to you about in a little while. And then healthcare policy, actually, our own NHS. If we look at our 2009 NHS constitution, we talk about patients as having rights. Patients have rights to be treated with dignity and respect. They have a right to free NHS treatment, and healthcare professionals have a duty towards their patients. They have a duty not to discriminate, and they have duties to provide a good standard of care. So why do we need to look at this question now? Well, despite all the advances in medical technology, 100% of people still die. I hope that doesn't come as a surprise to anybody, because you will all die. But really, our modern dying trajectory is very different. 50 years ago, people became ill and they died at home. They were looked after by their family, they died in their own beds. It would have been very common for children to have witnessed a dead body, even touched a dead body. Many scholars argue now that the subject of death is taboo, and others would say death is sanitised. Nowadays, people don't die at home, they die in a hospital environment or a hospice. We have healthcare workers, doctors and nurses, to perform all the roles in looking after the patient. We don't often see a dead body. Although the contrast to this is if you look at the BBC News, who are very good at covering crises, emergencies, wars, and we look at the horror films we can see in the cinema. I don't know if you've played Call of Duty or other video games. You know, you can actually set the level of gore when you're playing these video games. I think one of the reasons people look towards assisted dying as a possibility is perhaps that we're less community-oriented now. Years ago, people would meet in their community centres, their village halls, their churches, and nowadays, in my opinion, I think young people tend to go to work, they come home, they access their mobile devices. You can gain an awful lot of information, and yet you're there on your own to make and negotiate your own lifestyle choices and think about moral dilemmas in the privacy of your own home. Nowadays, we have a very different role with healthcare professionals. Many years ago, the doctor would come on his ward rounds, he'd stand at the end of your bed, he'd tell you what was wrong with you and what he was going to do about it. We don't have that now. I don't know, maybe you're the same, but if there's anything wrong with me, I've Googled my symptoms before I go to the GP, and I have an expectation that he's going to be prescribing something that I've read about online. So we have a much more consumer relationship, and I think Michelle is going to talk a little bit more about that later. So in the first stage of my research, I looked at the different debates on assisted dying in the House of Lords. It was debated for the first time in 1936 as a voluntary euthanasia bill. And at that time, the argument rested between merciful, compassionate release of a person who is suffering incurably. In 1936, there's no mention of rights, autonomy, patient choice. It was purely a medical professional mercifully helping somebody who is incurable to die. By 2003 and 2006, the ethos changes dramatically. There's a focus on personal autonomy and choice, the idea that an individual who is mentally competent and terminally ill should be able to ask for assistance to die. And I think this sums it up really. Lord Haskell says, we're here to serve the public as a whole. We legislate to preserve people's rights and freedoms. So by 2006, the emphasis is on choice. In 2013, the bill was debated in the House of Lords in July this year for 9 hours and 43 minutes. And I have to say, I didn't sit through all of it. It was really interesting, though. There was really a sense of respect and solemnity. All of the people who spoke used their full 4 minutes, and they all had a lot of convincing arguments, both in opposition and in favour of legalising assisted dying. I wonder if it was taken so seriously because there was a huge amount of letters written to peers in the House of Lords. So there was an overwhelming public response, which we might talk about a bit later. And also the Supreme Court had recommended that Parliament address the issue of assisted dying. So the debate now, today, I think, is summed up by Baroness Kennedy. She says, we're dealing with the right to individual autonomy and bodily integrity, and with the right to make decisions about our own lives. So it's a profound issue of human rights. On the other hand, there's a need to preserve the wider fabric of an ethical society with an overriding principle that human life is to be valued and guarded against violation and abuse. Okay, so if there were a right to die, what are the legal mechanisms that could support a right to die? Well, I'm sure many of you know, in 1948 we signed the Universal Declaration of Human Rights, protecting the fundamental freedoms, respecting individual dignity and worth. 1950 European Convention on Human Rights set out these freedoms, and 1998 the UK adopted the Human Rights Act. So Article 2 of the European Convention talks about the right to life. The right to life is an absolute right. Even in an emergency, we all have the right to life. Some scholars have argued that a right to life might involve a reciprocal right to die. When you look at the right to life, I think you have to look at the boundaries of that right. So do we have a right to life only if we have a good quality of life? What about if we're suffering terribly, we have no life quality, our life is not worth living? Can we then relinquish that right to life? Some people that have gone to the High Court and requested assistance to die have cited violation of Article 3 of the European Convention. They said that not being allowed to end their life amounted to torture or inhuman degrading treatment. Now, it sounds a bit far-fetched, perhaps, and my supervisor raised his eyebrows as well when I mentioned this. But if you think about doctors as being agents of the state, and somebody who is severely ill, perhaps suffering motor neurone disease and can't move, or a tetraplegic who's paralysed, and they're desperate to die, if they can't end their own life by legal means, is it degrading and inhuman not to allow them to end their life? Some people have quoted Article 8 and said we've got a right to privacy. You know, our lives are our own, they're private, we can do what we like in our own house. But in a democratic society, you have to balance the privacy rights of an individual against the welfare of wider society. Article 14 talks about discrimination. So if you are one of those people that I mentioned, you're unable to take your own life because you're physically disabled. What about then? What happens then? Your only option, if you don't have help to die and you're desperate to die, is to starve yourself. So if there was a right to die, let's say, there are some potential issues, and Michelle's going to cover these in depth a bit later. When you have a right to something, if you have a positive right to something, it often necessitates somebody to help you fulfil that right, a duty bearer. And the proposals so far have looked at medical professionals, doctors, being the people who would help you fulfil that right. But Michelle will cover that in a bit. For me, one of the greatest problems I see is that a right to die is culturally relative. People who want assistance to die tend to be white, middle class, upper class, educated, and often secular. Hindu, Sikh, Muslim groups tend to be opposed. And then for me, there's the question about whether a discourse of rights, when we talk about rights, whether we accept that the idea of a right to something evolves and reflects the society in which we live, or whether by allowing that to do so influences normative values. So there seems to be more prominent focus on rights. We have a right to this, a right to that. Is that okay? Or is that going to affect the fabric of our society? So as my research, I needed to look at who's defining the terms of the debate. So I've looked at campaigning voices, and I've done a case study of the organisation which Greg's part of, Dignity and Dying. I'm just going to make a couple of points on that, because he'll talk about that later. But I thought a definition of campaigning was really important here. Campaigning is organised actions around a specific issue to bring change in the policy and behaviours of institutions or specific public groups by mobilising others. So Dignity and Dying are an incredibly innovative, powerful, thank you, Lily. They're innovative, powerful, and they're dynamic, okay? They're a really good campaigning organisation. They have organised actions, they're striving to bring about policy change, and they're very good at mobilising the public. So by framing assisted dying as freedom of choice, focusing on human dignity and an expression of control. And their vision for the organisation talks about choice over where we should die, access to information about end of life, and control. And for me, because I'm interested in discourse, it's a really powerful discursive strategy. When you talk about choice and access, which are already present in our healthcare policy, and then you add on to the end control over when we die, by linking those ideas together, it sort of suggests it's a common sense. They should be together. When we have choice, we have access, we ought to really have control. And Dignity and Dying use specific tactics. I think their most persuasive campaigning tactic is that they've got a collection of personal stories on their website written by people who are dying or by families of those who have died. And these personal narratives really encourage proximity to the debate by giving some real life experiences. So for example, just one I picked out, the option of assisted dying would give me such comfort to know that I didn't have to go on suffering forever or have to take measures to end my life in another way. So aware that these personal stories reflect the ideology of the campaigning organisation, I wanted to look at other voices. I wanted to look at public voices. So I've been doing focus groups, small group discussions with participants who attend a death cafe that I facilitate in Hampstead, where people come together to talk about death and dying. We don't kill them off at the cafe, just in case you're wondering. And I wanted to talk to them about their opinions on dignity, suffering, choice, and rights at the end of their life. And I'm going to let their quotes speak for themselves. So one person said, "The thing that makes me angry is the disrespect for people who want to die. You're not allowed to say, 'I've had enough of this.' Everyone should be able to decide for themselves. I think that when people are old, they can be swayed. So there's the worry of undue influence. But I'm totally in favour of assisted dying. No one wants to die. What they want is an end to the conditions they are experiencing in that moment that is causing them to suffer physically or emotionally." I thought that quote was really insightful, and as a physiotherapist, that really resounded with me. We then went on to have a long discussion about whether anybody does want to die or they just want an end to the conditions they're suffering. And then finally, one lady, she was a severely handicapped lady, and as she left, she just threw out this comment, which was fantastic. "For all this publicity and everything going on about the bill, they're just clueless. And what we're doing here is getting to the bottom of what it's all about. So for me, that really authenticated my research. So in conclusion to our opening question, is it time to legalise assisted dying? If not now, then I think soon. Because I think any government that ignores the will of its citizens does so at its peril. And the reasons I think that it will happen is because of public pressure. Also because the nature of modern society. I think recommendations from the Supreme Court have an impact, as do campaigning strategies of powerful organisations. Thank you for listening.
Okay, and now we'll move straight on to Greg. Thanks very much.
I think in terms of the question whether we should legalise assisted dying in public policy, here and now in the United Kingdom, I think first of all we have to realise that public policy and the decision makers that make up the scrutiny of proposals such as this, they have many issues they have to contend with, both within a public healthcare realm of policy and in all the other public policy decisions they have to make in general. But assisted dying is different to many other policies that go across the desks of politicians, because it's a hidden problem. You have a range of other healthcare issues, such as an ageing population, the pressures of cancer drug funds, and the need for an expanding budget of the NHS. These are all things that people see day in, day out. The pressures of an A&E and at GP surgeries. But assisted dying, or the need for an assisted death by terminally ill people, is a hidden problem, because we don't like to talk about death. Death is a taboo, and people try and hide away from that, understandably. It's a difficult subject. Recent research by the organisation that I represent, Dignity in Dying, recently found that 7% of suicides in England, the people of that 7% have a terminal illness. And every fortnight, someone from the UK travels to Switzerland to die. But I hasten to add that those that travel to Switzerland, they only do so because they have the ability, the health to fly to Switzerland, which not all terminally ill people have. They have the money and the means to actually get there, which in essence is another barrier to people accessing clinics like Nicklinson in Zurich. And ultimately, 10 times as many people, dying people, are in their lives at home than the small percentage that actually go to Switzerland. So, some opponents, you may hear them say that we don't need an assisted dying law in the UK because there are opportunities and facilities available in countries outside, abroad. But that may be well, but research is showing that a very small percentage of people are actually using those facilities, when in fact the problem for people at home who they just can't travel for whatever the reason, that we still have an issue and a responsibility to hear their views and represent them. Now, Sharon very kindly sort of caused me a hiccup here, because I'm going to tell you a story, which is one of my campaigning techniques. And I think, it's all well and good talking about, statistics and figures and trying to quantify, the issue. But ultimately, thanks, Sharon, one of our key aims of the campaign is to really put a human face to the issue, because these are human stories, that have brought us to this point where we're campaigning publicly for a change in the law. One of our case studies, that we come in touch with is a woman called Heather Patton. Now, Heather isn't terminally ill herself, but her son was. He had Huntington's disease, which is a hereditary degenerative neurological disorder, and it gets progressively worse, and there is a terminal stage at the end. Unfortunately, on his 42nd birthday, he told her that the best present she could give him was enabling him to die, which was, I think when I spoke to her last, she said it wasn't an unexpected shock for her to hear that from him, because they knew, what the end point is with the disease. But essentially, what transpired is that she refused because she didn't accept that was the right thing for her to take part in. And he went off just out of the blue, missing eventually for 6 weeks. And he called his mum 6 weeks later, and he was in a small cabin in Scotland, and obviously they live in southern England, so quite a distance. And he tried to starve himself to death, which opponents say is another reason why we don't need to change the law, because people can starve themselves to death. That's another exit they can use. But it hadn't worked, and it was taking too long, the starvation process. And so she travelled up to Scotland and found him in a complete state, and essentially she helped him to die, and was put on bail for murder in the following weeks. And eventually, a year later, she was given a conditional discharge, so she isn't facing any criminal prosecutions now. And I think that's a key part of why we're actually campaigning for a change in the law, because under the current law, the Suicide Act, 1961, I believe, the punishment, the custodial charge can be a maximum of 14 years in prison. And under the assisted dying bill, which is being proposed currently by Lord Faulkner in the House of Lords, I think one of the key changes, which I've noticed from reading the policy, is that at the minute, just like with Heather's situation, the event happens, the assisted death happens, at like point A, and then all the investigation takes place after that point, and that's the point when your star witness, the person who has a terminal illness, for example, has died. You no longer have them there to give you a series of events and to help police and judicial authorities investigate the issue. Whereas under the assisted dying bill, one of the key safeguards is that the investigation process and the checks and balances is taking place before the death. And so that star witness, if you want to look at it in a criminal concept, that star witness is alive, maybe not well, but they're there to tell their story and to give testimony as to why they want to die. Now, one thing I want to clear up, because I know obviously I'm here to talk about disabled people and our relation to the bill and to the concept of assisted dying, but I know Sharon mentioned Tony Nicklinson, who I know some of you may have read up on this area of policy. Is a really prominent person. A few years ago, with the support of his family, he campaigned for assisted suicide. Now, assisted suicide, let's put it this way, I suppose. In the area of euthanasia and assistance to die, or the right to die well, there are roughly 4 key areas, or 4 key types of suicide, if you want to put it in those terms. And they can be split up on 2 principles: whether the dying person or the person who wants to die is doing so voluntary or involuntary, and whether they are going to self-administer or commit suicide by themselves, or they're going to have the action, the last action of death done against them or for them. Now, in terms of Tony Nicklinson, he was, and equally so, Paul Lamb, who is a paraplegic or tetraplegic, and who's currently fighting on behalf of Tony's case since Tony died of pneumonia several months ago now. They campaigned for assisted suicide, which is going to include disabled people as well, who are not dying from a terminal illness. Now, disabled activists for dignity in dying, who we should group I coordinate, we don't agree with that. We have actually quite strong reservations about assisted suicide, because I think ultimately, if you're going to make a law that has the proper safeguards and the proper social conscience and responsibility, it needs to be based upon natural lines. Identifying points that both people within the policy realm and also public support can understand that if you're terminally ill and you're dying, being assisted to die isn't killing you. You're merely enabling someone to take control of that dying process, which the only fault of that happening is sadly the terminal illness. Whereas if you have a disability and you want to die, you're interfering with your life path, with general, quality community care and support packages. There would be no reason why you would die at that point. You'd still carry on living, and so you're trying to interfere, with a living process, not a dying one. So yes, we campaign for assisted dying, and not for the other types of the right to die, and that's an important point to make. With Lord Faulkner's assisted dying bill, which is the current proposals that are on the table, they actually have been going through the House of Lords over the past year, and it was only last week we had the first day of our committee stage, which is where the House of Lords go through the detail one by one, scrutinising it to make sure it stands up to the view of the public ultimately. Now with the safeguards, which I think have to be the key part of the bill, to ensure that vulnerable people in the community are protected ultimately. You have to be terminally ill with less than 6 months or less to live, and that prognosis is to be decided by not just 2 independent doctors within the clinical setting, but we've actually just accepted a point that's been long proposed by the opposition within the debate, which is that there should be a judicial mechanism within the bill as well. And so Lord Panic put forward an amendment in the committee stage just a few weeks ago, saying that there should be an aspect of the family law division of the High Court which should be involved in determining whether someone is terminally ill, whether they're mentally competent, and whether they've made a clear and settled decision to end their own life. And so that's a really big step forward, because not only are we listening to the opposition and to people's genuine concerns, we're acting in a respectful and collegiate way to ensure that the bill has the confidence of absolutely as many people as it possibly can, because ultimately, if it's to become public policy, in some small way, we all have to respect it and take ownership of it, and so it needs to have the confidence of as many people as possible. One of the key area or safeguards which I think is really important is that the patient has to have an independent witness in the process. And I know a lot of people talk about undue influence and coercion, and I think actually having an independent witness who is not a relative, not a friend, or not part of your current clinical team, that's a really important aspect, to actually have someone witnessing the whole process, and to know that it is a reasonable process with the patient involved, at the centre of things. One thing I would mention is that a key point of the opposition is that Belgium and the Benelux countries, they have passed right to die legislation in the past, and there's a fear that we'll have this bill and then we'll go further and have the other types of right to die as well. But ultimately, countries like Belgium, they have set their policy out on a much wider spectrum from the very start, whereas the UK is following in the footsteps of US states of Oregon and Washington, who Oregon, they passed their law in 1997, so it's been going for 17 years now, and there's not been a legislative or public demand to extend it throughout the life of that term. I will end on the issue of disabled people and our support. Dignity in Dying has done a range of polls with independent pollsters on a lot of different subgroups and issues around the bill. And what we have found is that the disabled people, over 1,800, which were polled, that 79% supported a change in the law. And I know when you talk to groups like Not Dead Yet, they will say they are an opposition disabled group, and they will say the majority agree with us, and so understandably with polls you have other polls saying the opposite thing, and it's a bit of tit for tat. But I think ultimately what it shows is that disabled people are just like any other group. There is a spectrum of opinion. There are people with a range of views, and so it really opens up that debate. And so what I would say is that at the minute, when you talk to the disabled community, there is a tendency to talk about death in the negative, in terms of a victim type discourse, with people talking about killing and murder and having death done to you against your will. Where I'll just end on Sharon's point, talking about that 100% of people die at some point at the end of their life, and it's a taboo subject, like I said at the start, and that involves disabled people as well. We all are equal when it comes to the forces of life and death. And so what disabled activists for Dignity in Dying is attempting to do over the coming months and years is really try to get the disabled community to talk about death in the positive aspect as well. The end of life care, ensuring that disabled people, we get terminal illnesses as well as having a disability on occasion. Cancer and diseases like that can befall any of us, and so we have a right as well to talk about how end of life care should look for us. And yes, I think ultimately, only recently the deputy chair of the BMA, he said that he thinks after committee stage an assisted dying bill, a law, will become legal within 2 years. And he said that in the Observer just a few weeks ago. I think that's probably a little bit optimistic, but do I think assisted dying will be legal and protect disabled people in doing so by 2020? I think that's a good likelihood. Thank you.
Thank you very much. And now we'll move straight on to Michelle.
I've been specifically asked to talk about these issues, to consider the nurse and what nurses and doctors face in the midst of this debate. And I think it was once said that what's one of the biggest wonders of our human condition, or what's the biggest thing that we wonder about? And somebody once said, The biggest wonder of our human condition is death is all around us, visible, clear and obvious, yet nobody thinks it's actually going to happen to us. And we live with that contradiction constantly, and I think that's at the heart of this debate. But obviously, I can't speak for all doctors. I'm a nurse by background. I'm speaking here, and what I'm going to do is offer you a summary of what the research is from patients and professionals through the lens of 25 years as a registered nurse, working in trauma orthopaedics, helicopter emergency medical service in London, working in community practice, working with a range of people, but also 15 years worth of pain research, working with my palliative care colleagues around how to help people live with pain, and 5 years as a university chaplain. So that's the area that's the lens from which I'm giving you this work. I want to focus on three things that I've said there. And the first one is the clarity of terms. When we talk about assisted dying, what do we actually mean? And it's very clear that we all think we know what we mean, and we all have a particular definition. And certainly about your discussion about the assisted dying and assisted suicide being two very different things, as is euthanasia. And from a medical point of view, certainly the Oxford English Dictionary says assisted dying is the suicide of a person afflicted by an incurable disease using a lethal dose of drugs provided by a physician for this purpose. That's what the English Dictionary says it is. That's not what I think Dignity in Dying say it is. Dignity in Dying, the definition is assisted dying allows the terminally ill person to have choice. This is what Sharon was talking about, over the manner and timing of their imminent death. So two very different things, and yet they're both assisted dying. From a clinician's point of view, the clinical reality is assisted dying is a complex array of shared decisions about living and dying, because actually we don't flick a switch in our lives. One day we're not living and the next day we're dying. We are both living and dying every day. And some people are closer to it than others, but the reality is both of those things are happening. And when you're helping people with the end of their life, there are many things that shared decisions about living and dying are compacted into assisted dying. First, to choose or refuse life-sustaining treatment when it becomes burdensome or futile. Linda Bellingham is the latest example of that, deciding to no longer have chemotherapy. To choose or refuse indeed any treatment option for any reason. To choose supportive care when you want it, where you want it, where you would like to die, how you would like to die, and how you would like to be able to have your symptoms controlled. To choose to end your own life. To ask somebody else to help you end your life. To ask a doctor to provide you with the means to end your life or hasten your death. The first four are legal, and the debate circles round the last two. And from certainly my perspective, the debate is not about a right to die in terms of the legislative framework, but whether we as a society should give one person the freedom to end another person's life legally. And that's from a doctor's perspective. We're specifically talking about, should a doctor or nurse be allowed to end somebody's life? And as you've heard, doctors and nurses don't agree with whether there's a right or wrong answer to that. And there are proponents for. This is from the Journal of the Royal College of Physicians this year, with Graham Catto and Sir Graham Catto and Baroness Finley. Sir Graham Catto's view is, as a compassionate society, we should be ashamed and angry that we still deny the dying a dignified death so many seek. For too many grieving friends and relatives, the lasting legacy is not a life well lived, but of a grim, institutionalised death in uncaring surroundings. Although we wish to die peacefully at home, most of us will die in hospital. Why not ask patients for their views and provide a real choice at the end of life care? That's one medical position. Bironas Finley, on the other hand, says the real world of clinical practice is very different from the idealised world of these bills. They depict a doctor who has no strong health views themselves, so that they don't have an opinion over physician-assisted dying or assisted suicide, and they will be able to examine any request dispassionately, without prejudice, without time pressures of workload. A doctor who can confidently and accurately predict the course of a progressive illness, that his or her patients, they're able to know his or her patient's personal and family circumstances well enough to be able to say with assurance that there's no pressure, subtle or otherwise, working in the background, and that the doctor also will be able to assess the level of capacity that is required to make a decision, so that to assess that people are mentally competent and that there's no depression and there's no other reason why somebody may want to take their life. And in addition to that, they have to be independent from the case. And when doctors talk about this, the one point that I will make is it's a matter of fact that we know that predicting whether you are in the terminal phase of your illness is almost impossible to do. Doctors get it wrong all the time. And there's studies, one recent study showed that the accuracy levels were as low as 20%. Doctors cannot be certain that you're in the terminal phase of your condition. So actually, doctors cannot be certain about an awful lot when it comes to a progressive illness. They can't be, as Sharon mentioned, they can't be certain how you are going to respond to your symptoms. They can't predict how long you will have your symptoms. Indeed, they can't even predict how many symptoms you might have. They can have an educated guess, but they certainly can't predict with accuracy. And that's one of the challenges. But Sir Graham Catto says, really, and you're absolutely right, that the patient stories are very important, and they're very important to this debate. And I was very pleased to read a systematic review. This is why are people asking about the right to die? Why do we want it? And this is a systematic review. And systematic reviews pull together all of the available research in a particular area. They're a way of pulling together all of the studies, and this is a qualitative systematic review. So this is any survey, but also qualitative studies. And they were particularly interested, and the authors wanted to look at anybody who, the patient's views and opinions and perceptions and attitudes of anybody who's experienced assisted dying for adults, so that have been involved in either, have been part of a decision for assisted dying, have a terminal or long-term condition and they may have considered assisted dying. And there are 110 studies in this systematic review, 16 of which are qualitative studies gathering stories about how, why people were asking for the right to die, and 94 surveys. And they came up with 4 key themes, which we've touched a bit in this debate, but there's 4 key reasons why somebody would want the right to die. The first is a poor quality of life. And what I'd like to do is just take these 4 and talk a little bit about them. Poor quality of life, as a large term, is a very difficult term to grasp. But the groups of people in this systematic review described that a poor quality of life was feeling a burden on others, being dependent on others, being lonely, and extremely or poorly controlled pain, or indeed fear of it, because the difficulty is that it's a fear of poor quality of life. It's not a decision of where we are now. On a number of occasions, it was the fear of poor quality of life. But actually, in terms of the pain, this is a direct quote from one of the interviews. Pain also featured in the accounts of two patients, one of whom asked to be killed and one who attempted to kill himself. Neither acted to procure their death once their pain was under control. And this is a key reason why the Royal College of General Practitioners remain opposed to a change in the law, is that it has the potential to shift the focus from providing good quality of palliative care. And there is a real risk, and certainly the Royal College of Physicians also say this, palliative care, in the consultation exercises for the Royal College of Physicians, they say palliative care was widely seen as patchy and in need of investment. And I think it says something about our society that the vast majority of palliative care is delivered within hospices and is funded for by charitable donations. Most of our palliative care is not funded within the NHS budgets, but we talk about NHS budgets within palliative care. But certainly a large proportion of hospices are charitably funded. So certainly fear of poor quality of life. The desire for a good quality death, and that's defined as a right to choose, to retain control, the things that Sharon was talking about, but also to avoid pain. The most frequently cited reasons for wanting to have a patient-assisted suicide, a patient-assisted death, was a freedom to avoid suffering and avoid, again, reducing burden of family and loved ones. And again, this is another reason why most of the professions are opposed to a change in the law. For example, there's a recent survey, I don't know if you've seen, that just published recently, a survey of 7,721 responses in the Royal College of Nursing, say that many healthcare workers are profoundly troubled by an inability to always care for end-of-life patients in the environment that they would wish. The resources for... They talk about the resources. Almost half of responses suggested nurses do not always have the chance to speak with patients about their preferences at the final days. If you add that to the issues around being able to deliver compassionate care, the issues about being able to care for patients at the end of life, being known is a key factor. Being known when being sure that people are making the right decision about assisted dying is a key factor. And certainly the need for safeguards is a huge concern. The concern and these are patients' concerns, these aren't professional concerns. There's a concern that they're not concerned of physicians abusing. They trust their doctors to do the right thing of them, but they are aware that, and I like this, that doctors are not skilled enough to communicate about death and dying in their experiences, and doctors agree. The other particular event is the real importance of individual experience. The key fact here is if you have a good experience within your family network of death and dying, you're less likely to want to have an assisted dying legalised. If you have poor experiences, you're much more likely. Very often, this is another systematic review, and very often people say that, oh, well, what the doctors and what the public want are at odds. And what I thought I would do in my last couple of minutes is say that these are the themes from doctors. So if we think about the patients said, fear of poor quality of life, wanting good palliative care, the need for safeguards, what doctors are actually saying is they're not entirely sure, exactly coming back to Sharon's point about being the duty bearer. They're not sure doctors are the right professional group to be the people who make the decision. But they're also not sure that what we're doing is fundamentally undermining the social process of grieving. And the summary that I would leave you with is patients ask for the right to die because they fear poor quality of life. What we should be doing is increasing an emphasis on palliative care resources to meet everybody's needs. And that's not to say that sometimes that isn't able to do, but we should be, there's a real fear within the professional groups that if we legalise assisted dying, we're less likely to get all of the resources that we need for palliative care. Choice, autonomy and control. There's uncertainty about the role of the doctor and nurse. Doctors say, absolutely, we want to support patients' rights, but we recognise there's a power imbalance here. We recognise that a lot of patients would say, well, what would you do if it was your family doctor? What would you do? And we recognise that actually the amount of information that we have that we're certain of within nursing and medicine is not... our accuracy of diagnosis isn't, when you're wanting us to make decisions about this, we could get it wrong. What we need to do is models of shared decision making and make sure that we've got those models of shared decision making. When we talk about safeguards, what the general feeling is that actually in order to legalise assisted dying, the safeguards need to be upfront before you make the decision about the law. What we don't want is to effectively make it law and then try and work out the safeguards. That's a real challenge there. And the final thing is the individual experience of death and dying within your family. We've all had experiences. We all know just how much those experiences have an emotional toil. Equally, that's the same as the individual experiences of nurses and doctors. And when nurses and doctors are talking about their individual experience, my experience probably, I was hundreds of patients that I've had the privilege of journeying with them to the point of death. And lots of people have lots of voices to add to that. But if it does so, my final thing would be to say, if assisted dying becomes legal, we need to spare a thought for the nurses who are asked to do that and the emotional labour of doing that, and the governance of being able to do that, how we provide training, how we provide audits, how we make sure that that's safe. And I think that's
Great, thank you very much. Right, thanks to all three speakers. I'm sure you all agree, three excellent contributions, and I think they really kind of fitted well together, blending kind of academic campaigning and practitioner kind of perspectives on this issue. And I'm sure that everybody will share my view that whatever your thoughts on this were when you entered into the room, whether you sort of felt you supported assisted dying or not, you've certainly been given a lot of, a kind of pause for thought, a lot of issues there to think about.